Hello, everyone. This is Dr. Carson. I'm going to present to you a webinar on sexuality issues in the person with Alzheimer's, the role of the Alzheimer's whisperer. I have to tell you, this is becoming a much bigger issue in home care and in facility care. A number of years ago, Catherine and I attended a Alzheimer's conference in Minneapolis, and there were 4 different presentations on sexuality, and they all had a different slant. But what it said to me is this was becoming much more of importance, and that people were willing to talk about it. Next slide, Amy. Becoming an Alzheimer's whisperer. If you remember about the theory of retrogenesis, our name came from this the story of the horse whisperer. Tom Booker was a horse whisperer. His voice could calm wild horses. His touch could heal broken spirits. Tom entered the world of the horse gently and lovingly. He learned the horse from inside out. We try to learn the person with Alzheimer's, what is happening to them, what is their world. We enter their world and try to figure out what are the best responses to that changing world, because it's not our world anymore. Next slide, Amy. What is needed to become an Alzheimer's whisperer? Well, you have to understand that person's world, that's for sure. You have to have an easy-to-apply strategy to understand that world. You have to know or have the ability to assess where the person is in his or her progression in dementia. The ability to assess cognitive and functional levels, because people change. And so how they are in the early stages of Alzheimer's is definitely not how they are in the middle of the stage. The freedom to be creative, fun-loving, silly, and even childlike in our responses, so that there's no one right answer. Whatever works for you really makes the difference. And so just having some strategies, I think, opens up a lot of other opportunities for you to be creative. Next slide, Amy. This particular slide shows on one side my husband as the older person, once an adult. The theory of retrogenesis is once an adult, twice a child. So that we grow into adulthood, and then if you have Alzheimer's, you deteriorate going backwards, and you end up being like these 2 little guys on the side, both of them my grandchildren. One, the older one, was about 5 at that time, and the younger one was a toddler. And so those images really show you what happens with Alzheimer's disease. Next slide, Amy. The theory of retrogenesis literally means back to birth. It was created by Dr. Barry Reesberg at NYU. He concluded that Alzheimer's unravels or destroys the brain almost exactly in the reverse order as the brain develops. And developing means that all the neurons are myelinated from birth. And the first area to be affected is the hippocampus, and that is the storehouse of short-term memory. So for people who are caring for someone with a loved one, they'll know that the person asked the same question, even though they just got the answer just a minute or 2 ago. So they're used to and sometimes very frustrated by that lack of short-term memory. But this particular procedure or theory provides a method of creating approaches, environments, and techniques that are based on the developmental age of the person that correlates with the age of dementia, the stage of dementia. On this slide, the theory of retrogenesis, this really shows the whole theory really in pictorial form. On the left side, which is where the lavender line is, that's the development of a baby from birth on to adulthood. And so if we go through those signs early on, the baby holds his head up or her head up and smiles. Another sign of development is being able to go to the bathroom unaided, knowing that you've got to go, and then all dealing with the behaviors that go into being in the bathroom. And then selecting proper clothing, that's probably around a 4 to 5 year old. Handling simple finances can be anywhere from the teens on up to adulthood, and then holding a demanding job is at adulthood. On the pink side, what you see is that a person has a difficulty with a demanding job. They may still be in the workforce. If people like them and they cover for them, they help them do their job. If they're not likable, then people allow them to fail. And they probably don't know that the person has a cognitive problem and that's going to get worse. Coming down that scale on the right, people need help with complex tasks, menu planning, handling finances. This would be stage 4 probably on the fast scale. Then at stage 5, they need help with selecting and putting on clothing. Someone might appear to have gotten ready to go to the doctor, and maybe his or her daughter is going to take them, and comes out wearing underwear on the outside of their pants. A real wake-up call to the family member who's needing to take them to the doctor. And then the next step down would be the 6th stage on the fast scale, where someone really needs help with toileting, they're incontinent, they are really functioning at a pretty low level. And at the very lowest level, lose ability to smile or hold up head, then where that person is back to being an infant. And again, if you look over to the side where the baby's development is, one of the first signs of neurological development was holding the head up and smiling. And on the other side, the decline, the last big decline, is that ability to hold the head up and then smile. Next slide, Amy. This particular slide shows you the stages of Alzheimer's disease. The first and early stage lasts about 2 to 4 years and leads up to and includes the diagnosis. The person may live alone or with little supervision. We call them the great foolers because they're still able to do enough things that family thinks, oh, it's just because of aging, she had too much on her plate. And so they're able to fool people. The middle stage, stage 2, lasts 10 years. It's the longest stage, and it's probably the most difficult because people who are still in an adult body are functioning at a toddler level. And so we need to think about what is a 4-year-old deteriorating to a 2-year-old capable of doing. How do we supervise a toddler? Well, pretty much it's 24-hour supervision. How much care is needed? Safety issues become very important in this stage with people with Alzheimer's. Are they managing medication? Or you think they're managing medication, they're not. Are they still trying to drive? Well, they shouldn't be. So there are a lot of issues that come in this middle stage. It's like dealing with a toddler in an adult body. The third or late stage lasts 1 to 3 years, and usually we're giving palliative care. The person may be receiving hospice care. We think about an 18-month-old to a newborn, and then what are those ages able to do? We know that at those ages we're giving complete care. How does the baby communicate their needs? They cry, they whine. Total care is most likely needed due to the total body shutdown. Any sexual activity would be considered a rape at this particular time. And that's important. And if you look across, the person can give consent for sexual activity, and then in the middle phrase, the activity could be pleasurable, but the person, the consent is questionable in terms of sexual activity. Next slide, please, Amy. On this particular slide, it looks at issues for caregivers in assisted living facilities and in home care. And of course, you go into assisted living facilities so that families will, or the staff will be asking you about this. One is embarrassment. How do we talk about this with elderly patients and residents and or their families? How do we handle seeing or interrupting sexual activity? And you will be asked when you go into facilities these kind of questions because the staff there, for the most part, are very uncomfortable with this topic. They don't know what to say or do when they're confronted with sexual behavior. They're uncertain about the individual's ability to consent. Sometimes it's not easy to determine. Not the same as sex with a minor because most adults have experienced sexual activity, and it may be very much a part of their long-term memory. It could be a pleasurable or a very painful memory, depending on what their history was. We may not know that except by the person's response to sexual activity. But it brings up legal and liability issues in a facility, and that becomes a big issue when you are seeing someone in a facility because they're going to need your advice. Some other issues that come up in home care and in assisted facilities: the lack of privacy, the lack of a willing and able partner, so that sometimes people are seen masturbating a good deal to relieve those tensions. Mental illness. If the person had a mental illness and Alzheimer's overlapping with that, then really how are they able to consent? Physical limitations that occur with aging. Attitudes of staff get in the way, and that's home care staff as well as facility staff. The attitudes of family members can really make a big difference in terms of whether they accept this, they see this as a need and desire, or they're embarrassed by it and think their parents should know better. The adverse effects of medications may impact sexuality both from a positive or a negative way, meaning that some people could experience a greater sexual urge or a lesser sexual urge. The feelings of being unattractive certainly impact people as they age. Erectile dysfunction in men becomes a problem, so the desire may be there, but they are unable to actually perform. Painful intercourse might be a problem for women. It may bring back painful memories that are relived, i.e. of living with an abusive spouse or an abusive parent, a rape or sexual abuse from early stage in life. So as people deteriorate backwards, and if they are involved in any kind of sexual activity, it may generate very painful memories from their younger years. Issues for families confronted with sexual behavior of parents or elders. Embarrassment. Many times the reaction is, it's not my mother or not my father. No, they wouldn't do this. And there's a lack of knowledge about sexuality in the aged. I think for many people there's a sense that it stops at a certain age. Well, that's not true. Families may have a sense that it's morally wrong. They can't tell you why they feel that way, but that's their sense of feeling about this. They may place unrealistic expectations on assisted living to prevent sexual liaisons, and then the staff at the facility are saying, what do we do here? How do we handle this? Home care nurses sometimes get caught up in these issues if they are seeing a resident for care. Next slide, please, Amy. Recommendations from the American Medical Directors Association. And there, I don't even know if most people would even know that this had been printed, but I think it's a valuable piece of information. They're talking about enhancing staff knowledge, nurses, home care nurses, as well as inpatient and facility nurses or staff on issues related to geriatric sexuality. Include a sexual history and assessment in the patient's care plans. That may or may not be necessary in the home, but it certainly is something that we should be comfortable to talk about with family members who may be uneasy with watching a parent masturbate. Maybe they're masturbating in the living room when the children are watching TV, and they don't know how to handle that. Encourage staff and family members to discuss sexual issues encountered in a facility or home. Be aware of the cues that may indicate intimacy needs. Masturbating would be a big one. Promote privacy for individuals. Allow conjugal visits and/or home visits when people that are in a facility. Encourage older adults to meet, mingle, and spend time together. Encourage kissing and hugging. That may suffice without getting into sexual intercourse. Address individual sexual concerns. Make beauty salons and cosmetic services available so that the woman still feels sexually attractive to men. Provide sexual information and counseling to interested individuals. Provide sexual information to those who want to know. Educate families about sexual needs of the elderly. Evaluate via the medical exam the individual's complaints related to sexual functioning. And when I think I ought to mention to this, part of history is to find out whether someone ever had a sexually transmitted disease and did they get treatment for that. That would be a valuable piece of information. This next slide that looks at what are the facts about sexuality among the aged. Intimacy is a need to be close to be part of, to feel familiar with another person. It is a need of each and every one of us. Touch is vital to our well-being as people, regardless of our age. Touch is part of each of our identities and does not carry an expiration date. Those diagnosed with mental illness or those who are elderly are shown to be touched the least. Isn't there sadness to that? Human beings have an increased need for nurturing and touch as they age. The elderly who do not have family nearby often rely on healthcare professionals to nurture them. The next slide, please, Amy. Let's talk a little bit more about touch and its importance. What are the benefits of touch? It's therapeutic as a form of nonverbal communication. It decreases sensory deprivation. It increases reality orientation. It stimulates elderly minds. It decreases pain. It decreases isolation and vulnerability. It helps to form a sense of companionship. Touch is an excellent form of nonverbal communication. Think about how many times you put your hand on someone's shoulder, and it communicates, I'm listening to you, I'm here for you. We do that not only with our family, but sometimes we do it with people in their home that we're seeing as patients. We may do it to a friend as well. Caregivers describe a personal feeling of reward when intentionally, physically contacting another human being. So the caregiver themselves benefits from touch. Clinicians report excellent results with the elderly. Touch helps to promote sleep. It enhances feelings of well-being, and it decreases blood pressure. Who knew that all these things were benefits of touch? The lack of touch, however, may lead to increased sexual behavior as an effort to get a basic need fulfilled. Next slide, please, Amy. A little bit more on touch because this is a very important issue. A one-year study project looked at the effects of gentle massage on two groups of elderly nursing home residents, those suffering from chronic pain and those with dementia who exhibited anxious or agitated behaviors. What they found was touch decreased pain and anxiety scores in the patients, and in communication between patients and the staff was shown to dramatically improve. To the elderly person in a healthcare facility or in his or her own home, receiving touch in the form of gentle massage reduces emotional strain. And this would be something that we should be teaching families as well. Adding touch into care via massage might decrease sexual behaviors because people are getting those needs to be touched met in a non-sexual way. On this slide, it looks at some statistics. 75% of elderly people, 57 to 64, are still sexually active. 50% sexually active at the age of 65 to 74. 25% are sexually active age 75 or greater. Only 38% of men and 22% of women ever discussed sexual problems with their doctors. So it's not a topic that comes up between patients and their physicians. And so we may need to ask that if we're in a home and the family is complaining about sexual activity. On this particular slide, the impact of dementia on sexual behavior in generally is a reduction of sexual drive. It leads to many times sexual apathy and disinterest, and that's reported in about 25% of cases. That was a study done that was in 1995. An increase in libido is reported in about 14% of those elderly with dementia. The incidence of sexually inappropriate behaviors in the person with dementia are reported to be very low, ranging from 2.6 to 8% in samples of residents diagnosed with Alzheimer's disease. But if you look at that bottom phrase, if you are dealing with a sexual behavior, it seems like a major issue, and you don't think about it in terms of the low percentage. For you, it is a big issue, and for that facility, it's a big issue. This next slide looks at Sam, who had an unexpected STD. Sam, a 65-year-old, had recently been admitted to assisted living facility and was being seen by a home healthcare nurse for depression. Shortly after his admission, several lesions appeared on his penis and inner thighs. Initially, the nurses in the facility treated the lesions with a protective skin barrier, but there was no improvement. The nurses in the facility asked the home care nurse for her opinion, and she suggested a review of Sam's medical records. After reviewing medical records and consulting with a physician, they learned that Sam had contracted genital herpes almost 20 years earlier and still suffered outbreaks. In this case, proper treatment, infection control, and staff education were delayed because the nursing staff failed to quickly recognize a common sexually transmitted disease and now not read his medical record. And I think this really points out the fact that sexuality needs to be explored, and it also needs to be recorded, and we need to be reading those sources of information. On this particular slide, it gives some more facts about sexual behavior and dementia. The incidence of STDs among older Americans is on the rise. CDC Centers for Disease Control reports that 25% of Americans who are HIV positive are aged over 50 years of age. Chlamydia rates among men aged between 45 and 64 went up about 200% during the 10-year period up to the end of 2006, doubled among females. I think that's a shocking statistic, and one that should really alert us to the fact that we need to assess for this as well as we assess for other things like blood pressure and appetite and those kind of issues. Why is this increasing? Well, there's a significant number of elderly people are sexually active. Erectile dysfunction drugs such as Viagra, Levitra, and Cialis have allowed a greater number of older males to continue being sexually active. Studies have shown that STD rates among males using Viagra are double those of males who do not. These drugs have allowed men to be sexually active into their 90s. Older people are less inclined to use condoms compared to younger sexually active men and women. STD prevention and educational programs rarely address and include the elderly. Increasingly, ALFs and SNFs are requiring STD screening and a sexual history as part of the medical exam prior to entering the community. It's certainly not possible in home care, and so we need, if we're doing any kind of care, to always wear gloves. What are the causes of sexual behavior among those with Alzheimer's? Well, if you look at this particular slide, sexuality and the need for touch is our basic human needs. They don't go away. They don't have a time frame on them. The person might crave affection and affirmation that they may not be receiving. And with Alzheimer's, there's a loss of inhibition due to brain damage. The next two boxes, for some people, there's an insatiable desire for sexual activity due to brain damage. That's not the norm, but it can happen. They may be mistaking someone for one's partner. So they may see somebody who looks like their wife, and they see the person in another way. Masturbation and inappropriate undressing. Public masturbation is often very upsetting to the affected person's family, to neighbors, to paid caregivers. It is not malicious or perverted. It just feels good. The person has simply forgotten what is appropriate to do, that it's not appropriate to do it in public. Young children will grab their genitals as well, and they don't have a sense of it being inappropriate. Parents tell them to stop it. And so, but if somebody's going back to those early years, they don't remember that it's not appropriate. What do? Before deciding it's masturbation, check to see if the person needs to urinate. Children grab themselves when they need to urinate, and we're talking about people going back to childhood. It may look like masturbation, but result from the need to go to the bathroom. Acknowledge that it feels good, but it needs to be done in private. Removing clothing in public, what to do? Consider the time of the day. Could the person simply want to go to sleep? Consider whether the clothing are too tight or uncomfortable. Using fleece-lined sweats that are oversized and baggy usually takes care of that discomfort. They may need to use the toilet. They may feel too hot in their clothing. Putting an apron, a chef's apron on and tightening in the back makes the clothing hooks, buttons unavailable, and the person cannot get out of their clothing. So it makes it difficult for the person to disrobe. Inappropriate touching. Make sure that the caregiver does nothing to tempt the elderly person. Caregiver must dress and behave modestly. Sometimes the person with Alzheimer's is misinterpreted. We have to make sure we're not giving cues that could be misinterpreted. Sometimes the use of firm responses isn't enough. Mr. Smith, you cannot touch me like that, as the caregiver removes the offending hand. Walking away from the person when he or she acts inappropriately is also an approach. Review whether there is a particular time or place that this is happening. Is it happening during dressing or bathing, for example? If so, the caregiver needs to consider how to do these tasks in a very matter-of-fact way without reacting in a negative way to the person having an erection, perhaps. Sometimes the switching a female caregiver for a male caregiver and vice versa also helps to diminish this behavior. If all else fails, speak to the physician about medications that might dampen the patient's or resident's sexual energy. Next slide. Coming on sexually to own children. This is a really touchy issue for family members. It involves parents with Alzheimer's approaching their children sexually. This is not incest. It's the disease. Adult daughters and sons often look like their parents looked when they were younger and remind those affected by the disease of how their spouses looked years earlier. So in many ways, it's a case of mistaken identity. It helps a lot if the adult child who is being mistakenly identified as the spouse makes a point saying, "Dad, hi Dad, it's me, your daughter, your youngest daughter," and the name. It helps to take away some of that misidentification. Next slide, please. This information from Lichtenberg was published in 1997, and I know it is old, but there's not a whole lot out there that's newer. It's a decision tree that may help in deciding whether sexual activity is appropriate or not. Is the mini mental score greater than 14? And this may be very limiting. If it is, then the person probably can engage in sexual activity. If it's not, then it may be the patient's unable to consent. Performing a assessment, a verbal assessment, may help really guarantee if you're coming up with the right conclusion. Patient's ability to avoid exploitation, yes or no. If the patient is able to avoid being taken advantage of, then that person could probably consent to sexual activity. If they can't avoid exploitation, then they're unable to consent. Is the patient or the resident aware of the relationship? If the answer is yes, then you can continue the evaluation. If no, that means they're unable to consent. If the patient has an awareness of the risk, if that's true, consider that the patient's probably competent to participate in an intimate relationship. If your answer is no, provide frequent reminders of risk, but permit relationships. So it gives you a decision tree, and granted, this is an old piece of data, but it helps you make a decision. Having a specific policy that is understood by family members helps tremendously, and we can be influential in encouraging people in an assisted living to develop a policy like this. For example, a staff member finds an individual actively masturbating in a public area. There's a policy that would say, this is what you do. Let me move you to your own room. You will be much more comfortable, so that the staff member already knows exactly what's expected of them. A resident wants a professional caregiver to touch his penis. Using validation, the caregiver might say, "Mr. Jones, you really miss being close to a woman and having sexual activity." You're acknowledging his sexual feelings. Then you can reminisce with him. Do you remember the first time you had sex? Then tap into his visual memory. What did this person look like? Did she have blue eyes? Was she somebody that you really cared about? If the caregiver can use these validation techniques, then Mr. Jones can express his sexual feelings. He feels validated, and the validation tends to dissipate, and the feelings they dissipate and they lose their strength. Next slide, please, Amy. Lastly, what to say. You interrupt a couple in the midst of sexual relations. This is where a policy on conversation with family members really comes in handy. And I think it really helps if you can develop this in your own agencies as well, because you could actually come into a home and find somebody masturbating, and then how do you handle that? But in a facility, you might be able to give this to an assisted living facility as well. And in particular, Miss Jane, Mr. John, I hate to interrupt you, but I need Miss Jane to go down with me to the hall. So you're interrupting the activity. You're not making a big a fuss about it. This would be something to teach people in an assisted living facility to do, because I dare say that they're going to turn to you for advice about this, and you'll be prepared to give it to them. If, however, the family understands that sexuality is still part of their loved one's aging and can accept this, and if you see that the couple is mutually enjoying themselves, one does not appear frightened or intimidated, then that person can close the door and walk away. And this would be advice then you would give to people in an assisted living facility. However, if one of the participants seems frightened, uncomfortable, or intimidated, he or she, most likely a she, may not be fully consenting to sexual activity. Then the caregiver has to gently stop the behavior, not focusing on the behavior, but on the need for one of the participants to be doing something else. Redirection is a very effective intervention, and this needs to be reported to administration and to the family. So again, I can see people in the assisted living facility asking you for advice about this. This is some references, guys, that deal with this behavior. Lots of them. I think there's another slide that has references on it as well. If you want to check these things out, feel free to do this. Share them with facility providers, because they won't necessarily know all of the research that happens to be on this particular topic, but it happens to be a big one. If you have any questions and you want to talk to Catherine or Amy or I, you've got Catherine's number is on the last call, on the last slide. Mine is 410-336-5408. We're comfortable taking your calls. If you have a question either in home care or something comes up in a facility that you're in and you want clarification, please feel free to call us. Thank you so much for participating in this webinar, and we hope you have a good rest of your day. Bye-bye.